Next, we have Kotsu. She is a strategic lead for maternal health and early childhood development at Prokhelt. Please correct me if I said that wrong, Lauren. I realize this is the one thing that I didn't ask you how I pronounce. She will share her work on the South African National Development of Health's program Mom Connect. It is actually the department's COVID WhatsApp bot. And although this is a technology solution, you will see her background in service design shine through. All right, and Lauren's presentation was also pre-recorded, so if you want to interact with her in the chat throughout, you can. With that, I will share my screen and her presentation.
Hi, thank you for joining me, and welcome to the session called Designing for an Unequal Experience of Pregnancy and Motherhood. Now, if I can ask you for a moment to put everything else you may be thinking of or working on aside, and imagine for a moment that you're a woman living in South Africa and you've just found out that you're pregnant. You're in your late 20s and in a committed relationship with a father, and you're both happy that you're having a child. You have no underlying health issues. You're sitting in front of a screen right now, like your laptop. You have your smartphone right next to you as always, and a powerful Wi-Fi connection. And English is your first language. You start to Google about what to expect over the next few months. There is an overabundance of information available to you. It's overwhelming. But you have uncapped Wi-Fi, so you can browse through it all in your own time, and you find a few sites and apps that you trust and refer to those for the duration of your pregnancy. You've also been given a book by a friend about preparing for birth, breastfeeding, and sleep schedules, and you're working through that as well. You have 8 scheduled ANC visits that you will attend during your pregnancy with your private doctor. At each appointment, you have a scan and you can see the baby, and most wonderfully, you can hear the baby's heartbeat. You feel so connected to this baby already. The doctor spends time with you, checking how you are mentally, emotionally, and physically. She takes the time to discuss different birthing options with you, as well as working through any fears you may have. Together, you and the father attend private antenatal classes during your 3rd trimester, which really prepares you for the birth and the first few weeks of baby and breastfeeding. And when the time comes to give birth, you're nervous, but you're well prepared and ready for the journey to begin. You are part of the 20% of privileged pregnant women in South Africa that can afford private healthcare. Now meet Nandi. She has also just found out that she's pregnant, and very similar to you, she's in her late 20s living in South Africa. She's in a committed relationship with the baby's father, and they are both happy that they're having a child. She also has no underlying health issues. English is her 3rd language, but she understands it well. She has a smart feature phone, but very limited data and no Wi-Fi. She starts to Google about pregnancy, but runs out of data after 10 minutes, and she'll only be able to top up after payday. The next day, she goes to the clinic to confirm her pregnancy and find out more information about what she can expect. She leaves home at 5 a.m. feeling tired and nauseous and joins the queue at her local clinic at 6. One of the nurses is off sick, and the queue moves slowly. She finally sees a nurse at 2 p.m. The poor nurse is exhausted and only spends 15 minutes with Nandi doing the standard observations and explaining the bare minimum of what to expect. She just doesn't have the time to answer Nandi's myriad questions. There's a whole queue waiting outside for her that she still needs to get through today. Nandi is encouraged to attend 8 ANC visits during her pregnancy. And for each visit, she needs to take a day off work and spend many hours waiting in a queue just like today. When the time comes to give birth, Nandi is nervous and she's feeling underprepared. She's not sure what to expect of the birth, especially if all doesn't go, or how to initiate breastfeeding with her baby, and she doesn't know who she can talk to or ask for help. She is part of the 80% of pregnant women in South Africa that cannot afford private healthcare. And so, as you can see, Although there are many similarities between Sam and Nandi, there is one key difference. Sam has unlimited access to support and information about pregnancy and childcare, whereas Nandi does not. Now, let me give you a little more context about the environment in which Sam and Nandi live. The World Health Organization has estimated that 315,000 women die during and following pregnancy and childbirth every year. 2/3 of these deaths occur in sub-Saharan Africa, and most can be prevented. For South Africa, despite having one of the best economies on the continent, the country still sees a disproportionately high level of maternal and infant mortality, falling far behind the SDG to reduce the ratio to less than 70 per 100,000 live births by 2030. In addition to this, South Africa has experienced a major nursing shortage since 2010. Healthcare workers are overburdened, they're under huge pressure, are overworked, underpaid, and nurse burnout is common. We have many wonderful nurses in South Africa, but unfortunately, many have a reputation for abusing their power, being judgmental, discriminatory, rude, and rough with patients, particularly in a delivery room. I'd like to quickly pause here and introduce myself. My name is Lauren Kotza. I live in South Africa, and I was pregnant with my first child at a time when a project called Mom Connect was being designed. Through this project, I spoke to many women about their experience of pregnancy and listened in on focus group discussions with moms and nurses. I was surprised and worried by the things that women believed and had been told, shocked at some horrific stories, and really saddened that my experience of pregnancy was so completely different to many others, mine from a place of privilege and with private healthcare. And yet there was one central thread that united us all, that every single woman wanted to be the best mother they could be for their unborn child. At the time, I was a project manager, but this experience ignited a passion in me for maternal health and early childhood care. I became a service designer, and 7 years later, I'm now the strategic lead for maternal and child health at PlayGov.org. Jumping back to 2014, when I was pregnant with my first child, the National Department of Health in South Africa approached PlayHealth and asked us to help them better support pregnant women in the country. And so our first design challenge was, how might we get quality health information into the hands of pregnant women accessing public health facilities in South Africa? Of course, we quickly realized that if the program was going to stand any chance of success, we would need to consider and design for the extremely complex system in which it would exist. We would need to consider the needs of the three key stakeholders: the patient, the health worker, and the health officials. For the health system, if the project was going to live beyond the classic pilot period, the program would need to be sustainable. It would also need to provide healthcare officials with the right information in real time to empower them to make effective decisions to improve service delivery and quality. The health worker would need to play a pivotal role in this program, as they would be the ones to register women onto the platform, and so they too would need to feel supported and valued by the program if they were to support and promote it. For the patient, or in our case, the pregnant woman or mother, if the program was to have any impact, women would need to see value in the information and want to stay engaged. And so the information would need to be relevant to them, and it would need to come from a credible source. And most importantly, women would need to be able to access the information easily without any obstacles or barriers. And so with all this in mind, the design challenge was expanded to how might we strengthen the health system and sustainably get quality, personalized health information into the hands of all pregnant women in South Africa, so as to improve health outcomes for women and infants. And so in August 2014, Mom Connect was launched. Mom Connect is a South African National Department of Health initiative which aims to improve the health of pregnant women and infants at national scale. Through the platform, every pregnant woman can receive free, informative, stage-based messaging until the second year of her baby's life. I'll now talk you through the first design of Mom Connect and how we tackled each of the critical elements highlighted in the design challenge. And just to note that this was all achieved in the space of 3 months with a very tight deadline from the Department of Health, which made it that much more fun. In terms of accessibility, we needed to ensure we could get the health information into the hands of pregnant women. Now, many social impact digital programs hand out tablets or smartphones, but for real and sustainable scale, we opted for the technology that is in women's hands already. A technology called USSD, which, although definitely not the sexiest UX out there, is an extremely simple technology, which is universally accessible, even using the most basic of handsets. USSD was used for registering women onto the platform, and women would then receive their messages over SMS, an equally ubiquitous technology. We also ensured that messages were made available in all of South Africa's 11 official languages, ensuring that no one was excluded. Now, to get the service into the hands of all pregnant women in South Africa, we would need to make sure that not only was the technology highly scalable, but we'd also need to figure out where we could find all pregnant women so that we could register them onto the platform. And if there was one, this was probably the silver bullet for Mom Connect. The Department of Health added Link to Mom Connect onto the standard operating procedure for the first antenatal visit. In other words, if a pregnant woman visits a clinic at any point in her pregnancy, she will be registered by a nurse onto the platform. And largely because of this, Mom Connect became the first nationally scaled in-health platform at the time of its development. In terms of the project's sustainability at scale, it would need to be cost-effective for both the Department of Health and the end user. We managed to ensure there was zero cost to the mom, as all SMS costs were covered by the Department of Health, as well as inbound messages from the mom to the department. And at a $2 per person total project cost, it was certainly cost-effective for the department. Back again to the design challenge, to ensure that the health information was quality and personalized, it would need to be relevant. And so the messages created were stage-based, ensuring that a woman received information relevant to her stage of pregnancy or the age of her baby. This is only the tip of the iceberg in terms of what can be achieved with personalization, but more on that later. And if women were going to trust the information provided, it would need to come from a trusted and credible source. And so the content was developed by Baby Center, one of the global leaders in digital pregnancy and parenting resources, in close collaboration with the South African National Department of Health. And despite Baby Center's expertise, we of course ensure that they spend time in South Africa engaging with pregnant women and moms in focus group discussions, interviews, and user testing, and that the content was highly localized. PayCalc then worked on the brand persona, the tone of the messages, as well as ensuring the content was just right for SMS. In terms of strengthening the health system, as I mentioned earlier, this is achieved by understanding the needs of the key stakeholders and designing for them, the patient, the healthcare worker, and the healthcare officials. We ensured that healthcare officials had access to real-time data by integrating Mom Connect's pregnancy registry into the National Health Information System. A text-based help desk was developed to ensure a feedback loop from patients to facilities, and this resulted in early warning of local supply stockouts, as well as facility compliments and complaints being directed back to the facilities from the patients. And this helped improve centralized as well as facility oversight, further strengthening the system. And in terms of healthcare workers themselves, we developed a sister program called Nurse Connect with the aim of supporting midwives and nurses working in maternal and child health. So now to give you an update of where we are today, 7 years down the line. In terms of sustainability, despite the extremely low per user cost of the program, when you have over 1 million active users at any one time, the SMS costs per month are exorbitant. And this started threatening the sustainability of the project. So we had to look at alternative channels for engagement. MomConnect became one of the first non-profit platforms to leverage the WhatsApp Enterprise API. And so we began to transition the user base to WhatsApp. This led to significant cost savings as messages are free to send within a 24-hour window period. And it also allowed us to make the content far more engaging and interactive. In terms of scale and our goal of reaching national scale, the platform has 1.2 million active users monthly. Almost 4 million mothers have registered on the platform since 2014 in over 95% of public health facilities. In other words, 80% of mothers giving birth in public clinics have signed up for MomConnect. And the two-way help desk receives about 1,200 messages every day. In terms of impact, although incredibly overdue and another year overdue because of COVID, we are currently running an impact evaluation on MomConnect, looking specifically at family planning and breastfeeding outcomes. And we'll have the results by the end of the year. So that is something I'm really looking forward to. And so on to the future design of MomConnect. Our first priority for the first 7 years was really to make critical life-saving information available to all pregnant women in South Africa. And this has been our single-minded focus for the past 7 years. And as you can see from the previous slides, just to get it out there and make it available to everyone was no small feat. But now is the time when we can look forward to what MomConnect can be. So let's go back to Nandi. Now, if I can ask you to imagine that Nandi is actually a 17-year-old high school student. Her mother drinks too much and they don't have a good relationship. Her father is not around and never has been. Her matric ball is coming up and she's seen a dress that she'd love to wear, but she just doesn't have the money to buy it. She gets involved with an older man, what's called a blesser. He says he'll buy it for her. He has a bit of a dodgy reputation, and there's rumors going around that he may be HIV positive. But when you're that age and the dress is at stake, she falls pregnant and she's ashamed. Her mother is going to be furious when she finds out. She doesn't want to go to the local clinic for fear of anyone recognizing her from her community, and she's really nervous about taking the HIV test. When she finally plucks up the courage, the nurses are rude to her and they say she's a slut. And what is she doing pregnant at her age? They threaten to tell her mom. She's got no one to turn to and she feels completely alone. I'm sure you will agree with me that the support and information that this 17-year-old Nandi needs to receive during pregnancy is worlds apart from 25-year-old Nandi in a committed relationship and excited to have the baby. And those are just two versions of Nandi. Let's consider for a minute the multitude of factors that influence a woman's life when she's pregnant. Her health, risk factors, partnership status, employment status, mental health, sexual orientation, nationality, age. The list goes on and on. And Nandi could be any of 1,000 combinations of these factors, each combination resulting in a completely different experience of pregnancy. And this brings me to the questions that I'm currently grappling with in my design process. 1. How can we design personalized experiences for women with any of 1,000 combinations of factors relating to their social, psychological, and and environmental circumstances. 2, how do we continue to put the women that we are designing for at the center of the design process in the time of COVID-19? 3, how can we ensure the sustainability of this program, especially at a time when all resources are being redirected to the COVID response? And 4, how might we leverage the power of community during pregnancy and a child's early years with a program that is already at national scale? So to sum up, our new design challenge is as follows. How might we design a service that makes every woman feel understood, supported, and empowered in her unique journey to becoming a mother, and help her to adopt healthy behaviors for her and for her unborn child? I just want to leave you with 4 takeaways today. The first is that remember that even though information is widely available on the internet, not everyone is able to access it equally. 2, pre-COVID, women attended the clinic to get the information they needed. Now women are scared. Many women ask the help desk, is it okay if I go to the clinic? Can I go to take my baby for his vaccination? Is it safe? So the more information we can provide women on their phones, in their households, the better. And so I believe that digital tools are even more important now than pre-COVID. 3, the health system is complex, and a good design needs to take into consideration the needs of all the key stakeholders involved. And 4, innovation is not designing something with the shiniest, latest, prettiest tech. Sometimes it means designing within extreme limitations and still managing to provide a delightful user experience to the intended users exactly where they are. And that's the most important one for you. So thank you very much for joining me in this session.
Yay! Thank you, thank you, thank you, thank you, Lauren. That was amazing. Welcome, welcome. Wow, I really appreciate that, and I think it really resonated with folks that are here, if I may be so bold as to speak on many people's behalf. We have a few questions here, and then I have some of my own as well. The first one was from Rachel around what lessons you think can be applied for maternal health to other areas of health, if you have anything specifically to that.
Thanks, Odette. I'm certainly not an expert on any other areas of health, but I think the one thing I've taken, because my specific areas of interest are in maternal health and early childhood development, the differences in South Africa are certainly vast. In South Africa, we work very closely with the Department of Health, as I mentioned, in maternal health, and there's this very structured process that a woman needs to go through with her 8 ANC visits, and there's protocols for every single visit, and because of that, the results we've had in terms of prevention of mother-to-child transfer of HIV have been fantastic, and we've really seen some great strides in terms of maternal health and improvements in those health outcomes. But in the early childhood development space, we moved to a different department, a different ministry, and that's the Department of Basic Education. And where the Department of Health, every single clinic has a facility code, and so we can link a woman to her area where she comes from. In the Basic Education Department, they don't even know how many ECD centers exist. They haven't mapped them out. They don't have a database. And you can see how powerful it would be if we could feed the information that we have to that department and say, we know exactly how many babies are coming and when they'll be turning, the time, for instance, when they're going to move into creches or ECD centers. But there's just not that collaboration between departments, and they're just not as geared up. So I think just between those two, there's a lot of learning that could be had just in terms of collaboration between the private sector and the government, and also just the government department, embracing technology and really making use of it for their own needs. So, yeah.
Yeah, I know you and I talked about this, but I think really telling the stories firsthand really helped people understand what folks were going through, right? It created that felt experience that I saw people in the chat kind of experience and kind of bring up. Another question here is about how you can talk about how we may reach women who don't ever visit a clinic. I imagine it's hard to connect with women who are doing this entirely on their own.
Yes, that is a very tricky one. So, that's why there's obviously women that we just aren't reaching. There's, that 20% of women that we just can't get to. And so what we're trying to do now is work closely with organizations who work with community health workers who are in the communities and working with women in their houses and their homes. And so in that way, get MomConnect to those women as well. But the challenge again in South Africa is we don't have a very well-developed community health worker structure and system in place. There's nothing that's actually government owned. So there we're really falling behind. I know many other countries have fantastic systems. So, but apart from working with them, I don't know. I don't have any answers. So if anyone has any advice for us, please do share.
I love that response, the humility in it at the end too. We have a question from Liz. In response to the many factors and features of any individual that may impact their pregnancy and experience, how might we better design experiences for pregnant folks who don't identify as women?
Exactly.
This is a big one.
This is exactly what I'm grappling with. And I really don't know. I'm in the beginning stages of dealing with this. And I don't know. The only thing I can say right now is, we have to find people who are in that situation and bring them into the design process. That's all I can give you right now. But again, to find people in all these different unique situations and identifications is also, it's a challenge. How do you recruit people like that? What do you say? So that's also a very challenging one. So I don't know yet, but I'm going down that route right now.
Yeah, again, love the humility. One of the things that comes to mind for me is just, how are we even identifying people or asking them to identify themselves currently? Are we actually polling people to ask more than male, female? And are we actually asking for sex when we're saying gender? There's a lot that I think we as designers can do in thinking about how that information gets collected, right? So if you're designing a form and you're saying gender, man, woman, you're leaving a lot of people out of that experience and now bringing them into a fold where they could maybe share those experiences, right? So that's kind of part of my answer to your question, Liz.
Yeah, absolutely. And I think it's also a challenge. I was in a talk yesterday, I think we were talking about teams and how they asked the bare minimum of questions. Everything was anonymous and, you wanted to build this trust in the platform. And so in MomConnect, we do the same. We ask the bare minimum about what we really, really need. So we don't collect any of that data at the moment. And how are women going to feel when we start asking them a lot of identifiable questions and touchy questions? So it's going to be a challenging one for sure.
Right, especially I imagine in countries, I grew up in Istanbul, Turkey. We're not a very queer-friendly country. Part of the reasons I don't live there. We're also not very female-friendly at all. So, there's that added challenge of societal norms and how that builds into what people feel safe sharing about how they identify.
Exactly. And that's, also a part of the challenge of currently the program is South Africa specific, but I really want to be able to take it globally to anyone who wants to take it up. And it's an easy thing to take. But then, as you say, our perceptions are so different per country. And so you have to be very careful about how you design it. And, how do you take into consideration global considerations? It's very difficult to design something like that. So.
Yes. Again, a reminder that how much context matters.
Yeah.
All right, last question before we move on to our next speaker. How do you build trust in the platform among the community? And was there any resistance from patients or potentially care providers?
So this is a very good question. It's something that we actually really focus on is in all of our platforms across the board is this building trust and not just jumping into. So what we tend to do is actually and especially from Nurse Connect, I think I mentioned, and you were referring to health workers as well, is what we found out is that the content that we were sending health workers was valued, but more so the sort of resilience, psychosocial caring content that we send. And rather than, we thought the clinical reminders and information would be very useful, but it turned out that wasn't the case. And it's the same with a mom. She's going through so much, and especially in our target audience, that we really need to, especially in the sort of the beginning conversations with a mom, sort of really help her understand who we are, where we come from, or why we're doing what we're doing. And throughout the journey, then also just see her for who she is. She's not just a carrier of a baby. She is a whole person with her own issues and her own stuff, and really to provide content for her and for her well-being. So I think that's how we do it sort of throughout the journey.
Thank you for that great response and for your presentation overall. I'll see you around HXD.
Thank you so much.
Thank you. Talk to you later.